Mesdames, Messieurs, d'avoir.
Ladies and gentlemen, thank you very much for being here so late this evening. Might I begin by explaining to you how it is that an American is speaking to you in Jacques Brel's language? It's not because I live in Wisconsin, which is here in the USA. It's because I did my studies in Liège in Belgium. So this is my approach to the problem. I think this is a frontier borderline between oncology and nephrology. And this is where oncologists and nephrologists meet together or at the patient's bedside. So I discovered this problem, in fact, a long time ago when a doctor asked me about certain cysts in the kidney and associated cancers, the KI cysts in the. And then we looked at the chronic kidney the insufficiency. And then in the coming years, I had chronic renal failure. As the years went by, I realized that this frontier area, this boundary line, was extremely important and that it should be covered. So here are the problems that these are the issues that I'm going to talk to you about in this short time that's been given to me. So you have a lot of influence of kidneys on cancer and also of cancer on the kidneys. So we'll be looking of the incidence of cancer in terms of a CRF, which is chronic renal failure, and the exclusion of chronic renal failure from clinical trials, doses and therapies, which are very, very important, and of course the measurement of GFR and the glomerular filtration rate. So, on the other hand, we'll also look at kidney cancer, paraneoplastic syndromes, and treatment toxicity. I shall try and give you numbers for each in order to establish a sort of priority. But, however, we haven't looked at all parts of the whole issue. For instance, acute renal failure, malign urinary obstruction, paraproteinemia, and all sorts of other issues. And we could be here for days together to discuss all these different points. But I don't think I'll do that. So now here's a special case. This is a genuine case. So this is about a man who's 55 years old and who underwent cancer for the oropharynx. So he had diabetes and a DFG of less than 50 ml, a GFR of less than 50 ml a minute. Now, he was treated to cisplatin with radiation, but you oncologists, when the GFR is below 50, then you don't administer cisplatin, and you'd rather use other agents like carboplatin, paclitaxel, and cetuximab. So now, of course, it's for practical reasons and also, if I might say so, for other general reasons. Is it just by chance that this person had such a low GFR, or was it because of his chronic renal failure? When there is cancer, apparently it is true, this excess is not very high. Now, how do you measure the GFR? Now, my brother gave me this case. He's an oncologist, and apparently they use MDRD. But that's not true for all nephrologists. So you also have other possibilities. You've got the right formula, which is this one, number 3. Now, what is the chronic renal failure threshold? Is it 50? Is it 60? What is it? Well, I'll get back to that. But is it more than just a question of this? Apparently it is. In this article that was published a year ago, the prognostic or the outcome and the future of people for chronic renal failure treated with chemotherapy or cancer, their outcome or prognostic is more severe and not so good. Now, why is this being done? Because we, the research community, And the research community doesn't provide us with enough data. In all the clinical trials that I've seen, all the initial oncological clinical studies were involved in active recruitment. Now, 3/4 of these cases exclude people who have a chronic renal failure. And that's hardly surprising that we don't have any data related to any kind of efficacious treatment in patients who see an increase in the levels of creatinine. Now, how do you measure the GFR? A woman of 36 with a facial zoster, and she was treated, look at her serum creatinine, 97. Now, he's saying the numbers in the Belgian way. Anyway, it doesn't matter. You've understood. You've seen that you've got different results over here of how the GFR is calculated depending on the formula used. And how the GFR is measured in 24-hour urine. It's virtually half of what we find elsewhere. So then acyclovir was given in standard rates, a dose, and it led to a development of encephalopathy. As far as GFR is concerned, now you have a certain criteria for studies and also for everyday life. So which formula should you use? We don't really know. Some people believe that the right formula is the right one, the correct one. Anyway, there is a major difference, a major variation between the formula used and that adds to the complication. They don't know which formula should be used finally. And we also have differences between the FDA. Normally the FDA uses the Cockcroft Gold, others use MDRD, and the National Cancer Institute uses a series of 50, whereas for us it is 60, we in nephrology. So I hope, are in agreement that we should have a single calculation regarding the renal function in order to make research easier and its application in clinical life. Now, let's have a look at grafting, kidney graft. So apparently there is an increase in cancer after kidney grafting, after engraftment. But the major issue is, apart from just treatment, we need to actually do the screening. Is that worth it? As far as thyroidian cancer is concerned, this is a very infrequent cancer. So I started working on this problem several years ago. So this screening, is it worth it? You can calculate for yourself if you use all the medico-economic formula. It's $300,000. It all depends on the exchange rate, but let's say it's between, it's about 200,000 euros. So, and it is not efficacious. However, the cost of colonoscopy for cancer screening is fairly cheaper, even though it's not free. So if you put all this together, let's see what the numbers are. I didn't tell you about all the radiation-related risks because there's hardly any risk of induction of cancer due to imaging and so on. Or even if there is, it isn't of clinical importance. Now, cancer with chronic renal failure, we've already talked about, and it hasn't been clearly been identified. Now, cancer after engraftment, these are figures that come from the USA. You can divide them by 5 to apply them to France. So, in other words, it's a big problem if you have it. But in terms of, for the person suffering, it's a huge problem, but for public health, it isn't much. However, excluding people with chronic renal failure from studies and trials is a big problem. So now let's go on to the other side. Now this is what we were talking about, but the issues on the problems that we face. But this is the problem that is imposed by cancer on us. Now, here's another case: 55-year-old woman with a 3-centimeter tumor lump, and she's had a cardiomyopathy and serum creatinine of 150, or an eGFR of 30 ml. So it's either 40 or 50. So if you do a nephrectomy, she might just die. Now, this cardiovascular mortality is increasing because there is a loss of kidney function. However, if you do a cryoablation, then there's a certain stability in terms of mortality, which doesn't change. But we do hope that there will be a reduction in terms of cancer mortality without the problems faced by the operation. Now, this is what was done. I met her just a few weeks ago, and she appears to be doing fairly well. Now, to give you numbers, we have some data, and I've picked articles that appeared to me very clear on the issue. Here's one that comes from La Rochelle, an American, despite his name, who's written a G. Roll, who identified a risk, a terminal risk with chronic renal failure after a nephrectomy or partial nephrectomy on a single kidney. So if it's below 35 before the operation, that is the CRF, then there's a very strong possibility of moving towards terminal chronic renal failure. So now, what happens when it's both the kidneys, which is what happens very often? So if you start before, in the preoperatory stage, with a creatinine of 1.5, or let's say 120 units as per the international measures, then there is very unlikely that there be a terminal chronic kidney failure. However, if you start before the operation with a high creatinine, which is, let's say, around 2, then there's a strong possibility that it'll develop towards a terminal or chronic CRE. Now, let's look at the Paraneoplastic Syndrome. Man, 40 years old, with a progressive neuroblastoma, and there's a proteinuria that develops, and with a membranous glomerulopathy. So this was a Parisian study published a few years ago, and they covered a large series of virtually, and said that virtually 10% of the cases were followed by this sort of membranous glomerulopathy. So you can do a test for antibodies against PLA2R, and you'd see that there is also a mild inflammatory syndrome in the glomerules. However, this is not so common. Now, considering that the incidence of cancer is maybe 50 out of 100,000, and that of membranous nephropathy is as follows: 1 out of 100,000. As I said, 10% of these cases become paraneoplastic. So it's 1 out of a million. Now, let's look at treatment toxicity that you know ever so well, and which must be constantly kept in mind. So this is SFG after GDM was used for myeloma. This woman came to see me. I had read in the Journal of American Society for Nephrology just a week before she came to see me to consult me regarding this toxicity. So we have stopped the drug, withdrawn it with a good development and a stabilization of the renal function and a complete disappearance of the nephrotic syndrome. But it's not always that optimistic.
And all these substances can not only induce renal failure, acute or chronic renal failure, but also terminal renal failures. So let's try and quantify this. Matsushita carried out a study in Alberta, in Canada, and as he was carrying out the study, he asked people if they had cancer before the study, by thus demonstrating there was an excess of cancer amongst people who have chronic renal failure. You can prove that it's possibly cancer treatment that is to blame. So bone marrow transplant is a subject that I know fairly well. Chronic renal failure, on the basis of several studies, is a non-negligible complication of bone marrow transplant in 10 to 30% of cases in adults, but also in children. So, if we look at this specific toxicity that you probably saw 6 months, 12 months after bone marrow transplant, and particularly when there is conditioning using chemo and radiotherapy, you see the relatively quick reduction in renal function, and you can compare the glomeruli with the one on the at the bottom. It's rather of a glomerular nature, but it's not enough to describe diseases and syndromes. It's very nice and interesting for us doctors, but what matters, as it was underlined by the other speakers, is to do something about it, do something for patients. So, a prospective study, both randomized and double-blind, was conducted amongst patients on chemotherapy and having had a bone marrow transplant. What are the results? Well, there was a reduction in the number of cases, and there was an unexpected result, reduction in mortality, in pulmonary mortality, and an improvement in survival. This result is significant. So, the concept here is a concept of mitigation, introducing an agent after chemotherapy or radiotherapy, but before that stimulus has led to visible damage. You probably know the story of amifostine. Well, it can diminish toxicity, but that agent, even though it's toxic, can protect against cancer. Dexrazoxane is interesting in terms of targeted mitigation, but we currently investigate new mitigation agents to help mitigate the toxicity of radiotherapy. Of course, there are the new agents, all the MABs and the MIBs, but you have to be careful. Studies that we carry out that are with fairly restricted numbers are not enough to prove that it might apply to people who are older or who have more comorbidities. So, if I try to quantify these different problems, those paraneoplastic problems, it's fairly rare, so we should not blow it out of proportion. But chronic renal failure post-cancer should not be neglected. Nephrotoxicity is an important problem as well. So I think that priorities, therefore, are inclusion of chronic renal failure in clinical trials, reduction or mitigation of nephrotoxicity, and on a clinical level and in terms of daily practice, doses that are adapted to renal function. So in an effort, joint effort from oncology and nephrology. So I think this goes to show how important